Yeah, so I'll preface all of this by saying I'm not a biller, I'm not a coder, and I always get myself in trouble when I start talking through our rev cycle process and whatever we're going to do. So that's my caveat as we go through this. But I will say that at least from a business plan and ROI perspective, this has been a huge success for us. We feel that within the first 6 months we had overcome the capital outlay, and it was a quite frankly, the ROI on it was phenomenal. We've had great payer uptake on it. We did have to battle one at the beginning of this, but we've overcome that hurdle. We don't run into financial class issues for the most part, or payer class issues for the most part. We really seem to get good acceptance of this. And we've seen that performance hit our value-based contracts. We've been able to, it's hard to really, in a lot of ways, identify exactly what revenues coming in from a value-based contracting perspective, dedicated to certain specific measures depending on the type of contract. But we feel pretty comfortable saying that over the last couple of years, we've seen somewhere in excess of $300,000 come back in our value-based contracts just from our diabetic retinopathy screening. So that's not a huge number on a couple billion, but it's a big enough number to cover a couple of care managers and help us do other work. So we feel very good about the work that's happened there and the value that we get out of it from a value-based contracting perspective. We also see payment coming in on the fee-for-service side. So it does work out for us from a sheer math perspective. And then when you account for the fact that we are finding disease, we are taking care of patients who otherwise might have fallen through the cracks. This has been a major success for us. We feel really good about it. I think it's one of those things that I always say, if I'd have known that we were going to get the outcomes that we've seen, I would have pushed a lot harder. That 2-year conversation probably really should have taken just a couple months to get done. We don't look back at it at all and go, oh, we should have done this, or this. We feel very good about what we've done with it. And from a financial perspective, it's been a success for us. And from a patient care and outcomes perspective, it's been a success for us. It also links up, we do find some risk adjustment factor that aligns with it and helps us as we look at our overall medical loss reports on some of our value-based contracts. You can actually see some impact there. We do a pretty good job on capturing the HCC scores and risk adjustment factors across our organization. Dr. Markovich spends a lot of time educating our providers on how that works and what success looks like for us. And we feel really good that this has been a piece that has allowed us to capture some parts that wouldn't have made it into that component for us. So again, overall, I think for us, it's been a patient outcome success. It's been a financial success. We're seeing the impact in how we perform in our managed care contracts, and we're pretty pleased with it.
I'll add just a couple of comments from an Irish perspective. So like Hank, we are not billing experts. We are not a billing company. Iris does not submit claims for any exam conducted with any partner. Okay, so with that as the backdrop, what I can share with you is what we've learned from our experiences with clients like St. Elizabeth. And that is the most typical way that our clients are submitting for reimbursement is the use of a CPT code that's 92250. That code is defined as image capture and interpretation. And that code is submitted by the ordering physician most often across our client base. That would be, let's say that Dr. Markovich herself orders this exam for one of her patients one day, then that's the initiation of that dynamic financial transaction through her EMR comes from that ordering primary care physician. We do provide the interpretation services through our reading network that Hank mentioned earlier, but our readers are not submitting claims for the professional component of this. We assign that right through our contractual relationships over to our primary care partners, and so they are managing both the technical and the professional components of 92250. That is what we have seen. That is what we've observed from our clients. As with most things in life, there are exceptions and there might be other ways to handle this, but the overwhelming majority of our clients do indeed handle the claim submission process that way that I've just described. The second thing I would add is Hank mentioned from a RAF standpoint with these risk-based contracts that are becoming more and more prevalent. That's an additional benefit of that bidirectional EMR interface, in that as we return the result and the ICD-9 codes back to our clients, that assists in the electronic documentation of the higher level of complication from a RAF and HCC standpoint. So while it makes for a more efficient program for an ordering and resulting standpoint, it also benefits systems like St. Elizabeth, who are pretty heavily involved in risk-based contracts. So Hank, I appreciate your perspective there.